American Society of Maxillofacial Surgeons has a day designated to major topics in craniomaxillofacial surgery. And today, which is Sunday the 25th of September, we are focusing on panels highlighting some of those major topics.
The aesthetic refinements and using aesthetic principles in secondary cleft lip and palate surgery. Clearly, I think that everybody understands that the primary repair is your best shot at getting a great result and setting the stage for the prolonged treatment of these kids anyway. But it's really important to be able to follow up with sound secondary surgery, which virtually all of these kids are going to have.
Innovative techniques in head and neck reconstruction. I have a feeling that we're going to make some significant advances in using the computer-assisted design approaches, particularly as was discussed today. It's been a dramatic improvement in our ability to be accurate.
What we just participated in was a panel on expanding the practice of the maxillofacial surgeon, that is a plastic surgeon who specializes in maxillofacial surgery. And my contribution was using virtual computer planning in orthognathic or jaw surgery. And what that is it's the ability to move the jaws in a more favorable position to get a good occlusion or bite for the orthodontist. However, one of the benefits of using computer treatment planning is that not only are we able to get a good occlusion, but we're also able to do it in a way that optimizes the aesthetics of the patient. So my personal view is that the goal of jaw surgery is not just to get a good bite, but get a bite that actually optimizes the aesthetics of the patient.
We just finished a panel on what to do when a free flap dies. What's the next step? Is it still another free flap, or are there other options? We presented head and neck reconstruction, breast reconstruction, lower extremity reconstruction, and upper extremity reconstruction. And the take-home point is that often a free flap that is lost can be replaced successfully with another free flap. In every situation, this is one of the most difficult challenges that a reconstructive surgeon faces. There's emotional issues both on the surgeon's behalf and on the patient's behalf, as well as medical issues. And this is an extremely extensive surgery, and we have to remember that being good physicians foremost, we need to make sure that the patient is medically stable to undergo another extensive surgery.
I'm here today with Dr. Fred Minnick, and we've just come out of one of the sessions where we talked about soft tissue defects of the face and scalp. You know, one of the revolutionary things that you've been talking about now is not doing these local flaps on the nose, but substituting for skin grafts, and your results are spectacular. How did you have the courage to do that? It seems to be going against what people are talking about as far as more fancier and complex flaps.
Well, I was taught all the normal ways to do things, and just saw too many problems in my own hands or in patients that I'd seen who were unhappy. In a really practical sense, I learned from Barry Zeid, if you let a wound granulate a little bit, skin grafts take better. I knew that forehead skin was of great quality and had a different character than, for instance, preauricular skin. And it's a simple operation. I didn't have to reach far or do any, and there's no damage. So if a patient was unhappy, I was still in good shape.
The panel on the management of pain talks about the application of surgery for migraine headaches, which is certainly something that has not caught on in all medical centers, and that's certainly an area to pay attention to.
Actually came from a patient, a surgeon's wife, who came for a follow-up after having had forehead lift. She stated, not only I'm happy the way I look, I haven't had migraine headaches for a long time, since the surgery. And I thought that was a coincidence, but a few weeks later I heard the same story and it didn't sound like a coincidence. So we went back and reviewed and did a study, which was the beginning actually. We discovered that it wasn't a coincidence and offered the patients surgery as a pilot study. Then we did a more comprehensive study, and we have done multiple studies since to prove the efficacy and the longevity of this surgery, and we have been able to demonstrate that it really works and it lasts.
ASMS put together 6 panels that cover the whole gamut of aesthetics, reconstructive, and also practice management. And of course we had Dr. Kawamoto give us absolutely a wonderful lecture on learning from the masters, such as he is.
I think Joe Murray once said it very well. There are the 4 R's in surgery. I think it was recognition, resection, reconstruction, and now it's going to be replacement, or actually making the parts that we sort of borrowed and sort of they'll be making in the test tube and putting it back in. It's going to be an exciting time.
Primarily our focus has been in presenting short cases, summarizing great papers from the world literature that have to do with cleft craniofacial and pediatric plastic surgery, but also movies, short procedural movies, and other material that is very important for the education and the maintenance of certification. Our plans for next year is to involve more people. We need more people that will participate and will provide us with the material. PSEN has now a videographer, so we will be able to create important videos of major reconstructive procedures. And all this is very exciting, and we hope that next year, this time, we'll not only be able to double the material, but also put some more quality in the site.